Assalamu alaikum. In this presentation, we will discuss the disorders of the knee joint, focusing mainly on sport-related injuries. Let's have a quick review first of the knee anatomy. The knee joint is considered the largest joint in the body, and it is a complex joint that carries and bears the weight of the human body. It is considered a modified hinge joint. It is modified because it allows some degree of rotation with movement in the sagittal plane. The regular hinge joint allows only the movement in one plane, like the ulnohumeral joint, the interphalangeal joint. It allows the movement in the sagittal plane, flexion and extension. The main movement of the knee joint is flexion and extension in the sagittal plane, but at the end of extension, the tibia rotates externally on the femur. This is called the screw-home mechanism to add stability to the knee joint. So the joint itself, it is consistent of three parts or three joints. The lateral tibiofemoral joint, between the lateral femoral condyle and the lateral aspect of the tibia plateau. The medial femoral tibiofemoral joint, between the medial femoral condyle and the tibial plateau, and it carries most of the weight. 90% of the weight is bared on the medial aspect of the knee joint, as it is closer to the weight-bearing axis. And the small patellofemoral joint between the undersurface of the patella and the trochlea on the femur. The movement of the patellofemoral joint is cephalocaudal. It moves cephalic with extension and caudally with flexion. There are several factors playing a role in providing the proper joint function. When in the weight-bearing joints, when you need a lot of load transfer to be carried on that joint, you need more stability of that joint. Stability plays interchangeably with range of motion. Like in the shoulder joint, we need a huge range of motion, a circumduction movement, to allow for proper function of the joint. And that's why, as we need more range of motion, the stability of that joint will be less. In regards to the knee joint is the large weight-bearing joint of the body, so it needs a lot of stability. At the same time, we need some flexibility and range of motion in one plane and flexion extension to allow for walking and running. Now, the amount of weight transferred or loaded on a joint differs according to the activity. Like with normal walking, about 50% of the weight is transferred through one knee joint, because we have two knee joints, so each of the joints will transfer about 50%. But with increased level of activity, the level of load transfer will be increased. Like with running, you have almost 4.5 times the body weight to be transferred through each knee joint, and it is more with hopping and jumping. Several stabilizers have a role in joint stability. We can divide them into static and dynamic stabilizers. Dynamic means movement, that there is movement of that stabilizer, which means the muscles. So any muscle that crosses a joint and has a function on that joint will add to its stability. So in regards to the knee joint, we have the quadriceps in front, we have the hamstrings and the gastrocnemius in the back. The static stabilizers, either ligaments or shape of the joint itself. Now, the joint configuration of the tibiofemoral part of the knee joint doesn't add much to the stability. You have two femoral condyles, they look like a cylinder, on a flat tibial plateau surface. So, a cylinder on a flat surface doesn't add much to the stability. The patellofemoral joint, the shape of the patellofemoral joint, adds a lot of stability to its function. So there is a domed undersurface of the patella that runs in the trochlea, a groove. That's a saddle shape. That's add a lot of stability that allows movement cephalocaudal, as we said, with flexion and extension, but it prevents the patella from going medially or laterally. So for the knee joint, the tibiofemoral part, as we said that the shape and the configuration of the joint doesn't add a lot of stability to the joint itself. So to maintain the stability, we need a complex ligaments. That's why if you look at this image, you can see a lot of ligaments enveloping the whole knee joint. We have intra-articular ligaments, intra-articular structures like the ACL and PCL, anterior cruciate, posterior cruciate ligament, and a lot of extra-articular ligament, including the medial and lateral collateral ligament, the posterolateral complex, and the posteromedial complex. In this presentation, we will focus only on the major ligaments and major cartilaginous structures inside the knee joint. So the main cartilaginous structures that we're going to talk about is the menisci, the medial and lateral meniscus, and the main ligaments acting on the knee joint that we're going to discuss in this presentation is the ACL, PCL, and the collaterals. Now, if you look at the image on the left, you can see the intra-articular ACL and PCL, and they are named according to their tibial attachment. So the ACL is attached anteriorly on the tibia and goes toward the lateral femoral condyle, while the PCL is attached posteriorly on the tibia and goes anteriorly toward the medial femoral condyle. And they play a major role in preventing the anterior and posterior translation of the tibia on the femur. In regards to the collateral ligament, the medial collateral ligament from the medial epicondyle toward the medial aspect of the tibia, it's firmly attached to the medial meniscus. That provides a lot of stability to the meniscus, but it makes it more rigid and amenable for injuries. If you look on the lateral side, the lateral collateral ligament inserts on the femur on the lateral epicondyle and on the head of the fibula inferiorly. And you can notice that there is a space between the lateral collateral ligament and the lateral meniscus that allows for more flexibility of the lateral meniscus. Pain is the most common symptoms related to knee disorders. Pain due to knee disorders could be diffused or localized. Localized pain is usually due to a mechanical disorder or mechanical problem like meniscus tear or ligament tear. Diffuse pain involving the whole joint, the patient cannot localize it specifically. It could be due to an inflammatory or degenerative condition. With degeneration and osteoarthritis, the pain will be gradual in onset, while in acute inflammatory conditions like infection or crystal-related inflammation, gout, the onset of pain could be sudden. Swelling is one of the most common symptoms of knee disorders or knee fusion. Again, the swelling around the knee could be localized or diffused. Localized due to a structural or mechanical problem like a Baker cyst or meniscal cyst, while a diffuse swelling, it mainly means that there is an intra-articular problem, degeneration or inflammation. Stiffness and locking. Stiffness is loss of motion in the whole plane of movement. So with knee, there is a decreased range of motion in the flexion and extension, and it is there all the time, mainly due to degeneration. Locking means that there is a loss of motion in one plane in a certain direction, and it is usually due to a mechanical problem like a loose body inside the knee joint. So if there is a loose body inside the knee joint, the patient may not be able to do a full extension as there is a wedge blocking the knee from doing that movement. If he shakes the knee and the loose body moves to another place, then he can perform the movement easily. Pseudo-locking, its movement stopped suddenly and mainly due to pain, not due to a mechanical structure. Other symptoms related to knee disorders including deformities or malalignment, and we will talk about it in a bit. Giving way is a sign of instability. It means a sudden loss of posture. The patient cannot maintain a certain posture related to the joint function. Or loss of function. The patient is unable to do a certain movement or a certain function of the joint. Is unable to walk, unable to stand, unable to go down stairs or upstairs. This diagram shows the different causes of knee swelling and effusion. It can be either diffused or localized. The diffused part can be due to acute condition, due to trauma, to infection, or a chronic swelling due to inflammation or degeneration. The localized swelling could be localized to the front of the knee as a bursa, prepatellar bursitis or infrapatellar bursitis. Could be localized to the back of the knee as a popliteal cyst, a Baker's cyst, a popliteal aneurysm, or could be at the side of the joint like a meniscal cyst or a calcific ligament or bony swelling. Now, to evaluate any deformity or malalignment of the knee joint, we have to consider the normal physiological development of knee alignment. Geno means the knee, it's the Latin word for the knee joint. Varus is an inward displacement of the tibia, so the knee goes laterally, and valgus is the other way around. It's an outward displacement of the tibia and the knee goes medially. Now, all babies during infancy, they have a genovarus or a bow-legged knees. This normalizes to the age of 1.5 years. At 1.5 years, we have a straight alignment of the knee joint. After that, the normal physiological genovalgus starts to develop. It starts at around 2 years of age, reaches its maximum at about 3.5 years of age, and goes back toward the normal physiological adulthood valgus of about 5 to 7 degrees at 7 years of age. To objectively measure the amount of deformity before doing any x-rays and measuring angles, we can evaluate the genovarus or a bilateral bow-legged deformity by measuring the distance between the two femoral condyles, the two knees, by asking the patient to stand up, put the heels together, and you measure the intercondylar distance. Normally, it should be below 6 centimeters. Now, to evaluate a knocked knees, a genovalgus, you have to measure the distance between the two malleoli. Patient standing up, putting the knees together, touching the condyles together, and the distance between the two malleoli is measured, and it should be less than 8 centimeters. Now, at the image at the right, we can see that during infancy, the genovarus deformity, the normal physiological genovarus alignment, at 1.5 years, it is normalized. A straight line can pass through the center of the knee joint. After that, a genovalgus is developed, starts at 2 years, maximizes at 3.5 years, and then starts to decrease again toward the normal adulthood valgus at 7 years. When do we consider an abnormal alignment a pathological one? If the deformity is a unilateral, asymmetrical, then this is considered an abnormal malalignment. This could happen at the proximal tibia or the distal femur to affect the knee joint. Some of the causes that might cause a unilateral deformity includes injury, trauma, rickets, infection, or an inherent growth disorder. This X-ray and the clinical image shows an asymmetrical bow-legged deformity genovarus of the left knee. If it's severe deformity away from the normal physiological alignment that we talked about, even if it's bilateral, this is considered abnormal. This is a considerable severe deformity genovarus bilateral, it is symmetrical, but the degrees are very high, so this is considered a pathological malalignment. A progressive valgus deformity after the age of 7 years, we said that the normal adulthood valgus alignment of a knee joint is about 5 to 7 degrees. If it's progressive after the age of 7, increases with time, this is considered abnormal or pathological, even if it is symmetrical. How do we manage an abnormal pathological malalignment? If the growth plate is still open before the age of 16, growth plates affecting the alignment of the knee, the distal femur and proximal tibia. So a corrective guided growth can be performed by arresting the growth at one side of the knee joint using a stable or a small plate, as on the image on the right, and allowing the growth from one side to correct the deformity. This procedure is called hemiepiphysiodesis. So you arrest the growth on one side, on the long side, and allowing the growth on the short side to correct the deformity. Once the deformity has been corrected, the plate or the stable is removed to allow symmetrical growth on both ends. If we pass the age of open growth plate, we can do a corrective osteotomy. The corrective osteotomy could be an open wedge or a closed wedge osteotomy, either taking a wedge from the bone and closing it on itself to correct the deformity, or inserting a wedge after cutting the bone to do a correction. So on the image on the right, you can see the open wedge osteotomy. We open the wedge, we inserted a bone graft and put a plate on top of it to correct a varus deformity. The other image, it is a closing wedge osteotomy. You cut a wedge from the bone, you close it for a genovalgus deformity to correct this deformity. In elderly, if the varus deformity due to degenerative or traumatic changes, a severe osteoarthritis, this can be corrected by a joint replacement. In the second part of this presentation, we will talk about soft tissue injuries, including menisci, ligaments, and cartilage and tendons around the knee joint. The knee joint is one of the most vulnerable joints for sport-related injury and injuries in general. That is because it is a weight-bearing, load-transferring big joint. It is highly mobile to allow for movement, and its articular surface is at only minimal contact of the whole surface area during the range of motion. The stability of the knee joint depends mainly on the surrounding ligaments and dynamic muscles. As we discussed earlier, the shape and the configuration of the tibiofemoral part of the knee joint doesn't add a lot to the knee stability. On the articular surface of the tibia, we have two menisci, a lateral one and a medial one. The medial meniscus is more of a C-shaped, while the lateral meniscus is more of a circular meniscus. Each of these menisci are consistent of three zones, an anterior, posterior horn, and the main body. The body of the medial meniscus is firmly attached to the MCL. That makes it more fixed, rigid, and not flexible, while the lateral meniscus is not attached to the lateral collateral ligament. That makes it more flexible. The meniscus itself is consistent mainly of collagen fibers. These collagen fibers, most of them are arranged in a circumferential longitudinal pattern. Starts from the anterior horn toward the body and then to the posterior horn. And there is some anchoring radial and random collagen fibers to hold these longitudinal circumferential fibers together. The function of the meniscus is mainly to help enforce transmission. They act as a shock absorbent. They increase the congruency of the flat tibial surface and increase the contact area to decrease the point loads and the force pressure transmitted from the femur to the tibial side. 50% of the weight is transmitted through the menisci in extension, while 85% of the weight is transmitted through the menisci in flexion. The meniscus itself acts as a secondary stabilizer. The wedge shape effect of the menisci on the medial and lateral aspect prevents the tibia from sliding anteriorly and posteriorly on the femur, so it adds to the stability of the ACL and PCL structures. So as we discussed earlier, that 90% of the weight is transmitted through the medial compartment, through the medial tibiofemoral joint, and 85% of this load is transmitted through the menisci in flexion. That's a huge amount of load transmitted through the medial meniscus. That's why we need a rigid meniscus on that area. The rigidity of the medial meniscus by its firmly attachment to the MCL makes it less flexible. This makes it more amenable for injury with any abnormal movement. The medial meniscus is more common to be injured in comparison to the lateral, more flexible lateral meniscus. The injury itself to the meniscus usually happens in flexion, rotation, twisting, and axial loading. So with this type of movement on a rigid surface, rigid meniscus, this can easily tear the medial meniscus. The most common type of meniscal tear is the longitudinal or the vertical tear, as this direction of tear goes with the direction of the circumferential fibers of the circumferential collagen fibers forming the meniscus. Radial tears is a tear directed from the inside of the meniscus toward the periphery of it, and horizontal tear can easily notice it on the image on the right in a 3D structure of the meniscus. Our progression of these primary tears can lead to different type of tears. If a horizontal tear progresses, it can lead to a flap tear. The flap tear keeps irritating the knee joint and causing recurrent fusion. A progression of the radial tear can lead to a parrot beak tear. A progression of the vertical tear will lead to a bucket handle tear. Now the bucket handle, it is attached on the anterior horn and posterior horn, and most of the body part is torn. This part keeps flipping inside the joint into the intercondylar area and back again in its place. Now once it is in the intercondylar notch, this part could be entrapped between the femur and the tibia and causing a locking of the knee. The patient will be unable to fully extend his knee. Most of the meniscus is avascular structure. We can divide it into 3 zones. The outer 1/3 is called the red zone that receives a blood supply from the geniculate arteries, the medial and the lateral geniculate arteries, while the inner 2/3, the red-white and the white-white zone, are avascular. That makes an injury to the outer 1/3 can be healed if repaired, while an injury for the inside 2/3 are less viable and makes healing at that and those 2 zones difficult. In regards to that, do you think a meniscal tear will cause a hemoarthrosis of the joint? Usually not. So an injury to the meniscus will not cause hemoarthrosis of the knee joint. Symptoms associated with meniscal injury, usually it's pain localized to the joint line, either medial or lateral. The swelling or effusion of the knee joint is usually delayed and intermittent, and it is due to irritation rather than hemoarthrosis. If the tear progressed even more, this might cause mechanical symptoms, including clicking and locking, as we discussed earlier. When all of these initial symptoms subside Any trivial twisting or strain or load on the knee joint may cause an irritation and effusion, recurrent effusion. On examination, the patient usually holds his knee in a slight flexion, either due to the amount of fusion inside the knee joint or due to locking with bucket handle tears. With late presentation, usually the patient presented with a quadriceps wasting. Tenderness over the joint line, either medially or laterally, is the most sensitive sign for meniscal tear. Special tests that we're going to discuss now are called the McMurray's, Apley's, and Tisby test. All of these three tests, they use the same mechanism of injury for the meniscus. As we discussed earlier, the meniscus is usually injured in slight flexion, axial loading, and twisting movement. In McMurray's test, the patient is supine, the knee is flexed, you load the joint with valgus and rotation, and you can hear a click, an audible click, to indicate a positive test. Apley's test, the patient is prone, the knee is flexed, you load the joint from the top, and you do a twisting movement, and the patient will complain of discomfort or pain. Tisby test, the axial compression is maintained by the weight of the patient. You ask the patient to stand, slightly flex his knee, and start rotating from one side to another, and this will cause discomfort or pain to the patient. Imaging of patient with a meniscal tear. X-ray and conventional radiographs are usually normal in young patients with acute tears. But with late presentation, you might be able to see some degeneration or degenerative changes inside the knee joint. MRI is the diagnostic imaging modality of choice. It is the most sensitive diagnostic test for meniscal tears. You can see an increased signal intensity on T2 images with a tear as on the right, on the sagittal view, as well as on the axial view. On the sagittal view, we can see a horizontal tear of the meniscus. On the axial view for another patient, we can see a radial tear of the meniscus. How to manage a patient with meniscal tear? Usually treatment is conservative with rest, ice, analgesic, and elevation. Start physiotherapy to strengthen the muscles around the knee joint. This will provide stability and support to the knee joint. For operative management, it is indicated if conservative management failed or if the mechanical symptoms are present. If there is locking, continuous painful clicking, then you do arthroscopic treatment. With arthroscopy, it is both diagnostic and interventional. So you can diagnose and identify the extent of the tear on the meniscus. You can examine it, and then you can perform your management on it. If it's acute tear in the outer zone, the vascular zone, you can repair it easily and you hope for it to heal. If it's complex tear in the inner 2/3 in a bit older patient, then usually we remove part of the meniscus. We perform partial meniscectomy to avoid the continuous irritation of the joint with continuous flapping of this torn meniscus. Another pathology associated with meniscal tear is the meniscal cyst. Meniscal cyst usually present on the lateral side of the knee, as there is a space between the lateral meniscus and the lateral collateral ligament. The medial side is firmly attached to the MCL. There is not enough space for outpouching of the capsule and forming a cyst. So with the torn meniscus acts as a valve that allows synovial fluid and knee effusion to escape the knee joint, causing an outpouching of the capsule. This cyst usually contains a gelatinous material, an organized synovial fluid, and forms a small lump outside of the joint. This lump can be identified clinically, and usually it is tender to palpation. How to treat a meniscal cyst? You have to treat the causing agent, the meniscal tear. So you can aspirate the meniscal cyst to relieve pain for the patient, but you know for sure if you didn't treat the tear itself, a recollection will happen easily. So you have to do an arthroscopy, treatment of the tear, either by repair or meniscectomy, and evacuation of the cyst to relieve the patient's symptom. Let's move on to discuss the ligaments injury of the knee. So there is a grading system for ligament injury. Grade 1 is a sprain of the ligament. So few fibers are torn, but the main bulk of the ligament itself is still intact. This will cause pain to the patient, but it won't affect the stability and the function of the ligament itself. In a grade 2, there's a partial, incomplete, torn ligament. This might affect the function of the ligament and cause the patient continuous pain. In grade 3, there's a complete tear of the ligament and causing a complete instability and dysfunction of the ligament. ACL is the most common injured ligament of the knee joint. It happens mainly due to non-contact type of injury, a pivoting injury. The tibia translates anteriorly with slight flexion and valgus. It is more common in female in comparison to male among athletes. That is because females have a smaller ligament, a tighter intercondylar notch, and a different landing mechanism in compared to males. The ACL is consistent of two bundles, the AM bundle, the anteromedial bundle, and the posterolateral bundle. The anteromedial bundle is isometric, which means it is tight in flexion and extension, while the posterolateral bundle, it is tight in extension and it provides stability for rotation. A patient presented with ACL injury, they can recall the exact mechanism at which the ligament is injured. It is really painful. He can hear or feel a sudden pop of the ligament. The knee swells immediately due to hemarthrosis, as the ligament is a vascular structure, with a deep knee pain. It is usually difficult to examine patient with an acute ACL injury presented due to the ER with hemarthrosis and swelling. But after the initial period of time, after the hemarthrosis subsides, you can test the stability of the knee joint. Ligament test is the most sensitive test for ACL injury, in which you hold the femur, you hold the thigh with one hand, you hold the tibia or the leg with the other hand, and you try to translate the tibia anteriorly at 30 degrees of flexion. Anterior drawer test is another test for ACL injury. With the knee flexed to 90 degrees, you can hold the tibia, the leg, and try to translate it anteriorly. More than 8 millimeter anterior translation of the tibia indicates a full tear of the ACL. PCL is the main restraint for posterior translation of the tibia on the femur. It attached posteriorly on the tibia at the PCL sulcus and goes anteriorly toward the medial femoral condyle. Injury of the PCL usually happens due to a direct hit, a contact type hit on the tibia from anterior to posterior, like with dashboard injuries. Usually the patient presents with sudden onset pain due to the rupture of the ligament with a huge swelling inside the knee joint, as the PCL is an intra-articular vascular structure. Collateral ligaments. Medial collateral ligament is attached medially from the medial epicondyle to the medial surface of the tibia, and they prevent valgus instability, while the lateral collateral ligament attached from the lateral epicondyle to the head of the fibula and prevents varus instability. A sudden hit or a contact type hit on the knee joint from the lateral aspect or on the tibia from the medial aspect will cause an MCL injury. A direct hit on the tibia from the lateral aspect or on the knee joint itself from the medial aspect will cause varus and injury to the LCL. To examine the knee for PCL injury, you flex the knees to 90 degrees and you hold the legs of the patient. Now, by the weight of the leg and the tibia, the leg will translate posteriorly as there is no restraint with PCL injury. This is called the posterior sag sign or sag test. As well as you can perform a posterior drawer test, the same mechanism as the anterior drawer test. You flex the knee to 90 degrees, you hold the leg, and you try to translate it posteriorly. A translation more than 10 millimeter indicates a complete PCL rupture. To test for collateral ligament integrity, you can perform stress tests, a varus or valgus stress test. With valgus stress test, you hold the knee and you stress the leg into valgus. This will strain the medial collateral ligament. An opening of the medial side indicates an MCL tear. For varus stress test is the complete opposite. You hold the knee and you try to stress the tibia into varus. This will strain the lateral collateral ligament, and an opening on the lateral aspect of the knee joint. This indicates a lateral collateral ligament rupture. The test is performed at full extension and at 30 degrees of flexion. Opening at 30 degrees of flexion indicates an isolated LCL or MCL tear, while opening at full extension indicates a collateral ligament tear plus an intra-articular ligament tear, mainly the ACL. Imaging of ligament injuries of the knee involves conventional x-rays. Now, with conventional x-rays, you can see if there is an avulsion at the insertion site of each of the ligaments. For MCL, an avulsion usually happens on the femur side over the medial epicondyle. For the lateral collateral ligament, it can happen on both sides, but more common on the fibula. For the ACL, usually it happens at the tibial spine, tibial eminence in young patients. And for the PCL, it usually happens at the PCL sulcus, posteriorly on the tibia. You can perform stress radiographs like you do in your examination and image any opening of the joint line. You can notice on the X-ray on the right, there is an increase in the opening with stress about 8 millimeter. This indicates a complete MCL rupture. Another sign, these are X-rays for avulsion of each of the ligaments, an MCL avulsion from the medial epicondyle, an LCL avulsion from the fibula, a posterior sulcus avulsion due to PCL injury, and an ACL injury with intercondylar eminence avulsion. Second fracture is a pathognomonic X-ray finding associated with ACL injury. This happens due to the anterolateral ligament injury. Ligament or thickening of the capsule extends from the lateral epicondyle, femoral epicondyle, toward the lateral aspect of the tibia. It has the same path as ACL, so it is sometimes avulsed or injured with ACL injury, and you can see it on the X-ray. MRI is the most sensitive test for diagnosing any ligament injury. How to treat a sprain or a partial tear of any ligament around the knee? Usually the treatment is conservative. The conservative treatment means you have to give the patient analgesia to put the knee at rest, put it in a functional knee brace to allow for movement, and to use ice and elevation to prevent the swelling from causing the patient any pain. Now, draining or aspirating the hemoarthrosis, the intra-articular hemoarthrosis, is controversial. It can relieve the pain of the patient, but you might introduce a microorganism that might cause an infection inside the joint and septic arthritis. The main thing with conservative treatment is to maintain the movement. If you kept the limb in a cast, you will end up with intra-articular adhesions and loss of motion of the knee joint. Management of complete tears of the ligament depends on the ligament itself and on the host, on the patient. An isolated MCL or LCL injury usually treated conservatively in a functional knee brace. An isolated PCL injury is treated conservatively as well. An isolated ACL injury in a young patient or athlete has to be reconstructed surgically. Treatment of a complete tear should be followed with an intense rehabilitation program to strengthen the muscles around the knee joint and to maintain the range of motion. Avulsion of a ligament usually treated operatively if displaced. So you have to put the avulsed bone back in its place and fix it with a proper fixation method like a screw. Combined injury, a combined ACL, PCL, or collateral ligament injury, you start with reconstructing the ACL and put the knee in a functional knee brace to allow for the other ligaments to heal and evaluate afterward. Combined medial and lateral collateral ligament without an intra-articular ligament injury, usually treated conservatively. With PCL, a combined PCL and collateral ligament injury usually needs to reconstruct the PCL and reconstruct the extra-articular ligaments as well. One of the devastating injuries of the knee is called the O'Donohue's triad or the unhappy triad. The unhappy triad happens while the knee is fixed on the ground and a direct hit to the knee comes from the outside. This leads to a medial collateral ligament injury, and as the medial meniscus is attached to the medial collateral ligament, it will get torn as well, and the force continues to the intra-articular structure, injuring at least the ACL. This is one of the devastating ligamentous injury of the knee that requires surgical intervention to maintain the stability of the knee joint. Osteochondritis dissecans is a pathological lesion of the articular cartilage of the knee. From its name, it has an osseous part, the osteopart, a bone, a chondritis, a cartilage covering, and it looks like a disc, dissecans. 80% of the cases affects the lateral aspect of the medial femoral condyle of the knee joint, and the 25% of the patients has it on both sides. Usually the patient presents with mild pain, poorly localized. If the lesion itself became as a loose body, it might cause locking inside the knee joint. But the usual presentation is mild pain with recurrent effusion. To examine for it, you have to do a palpation of the lateral aspect of the medial femoral condyle, just medial to the patellar tendon, and you can focal a localized pain and tenderness in that area. And you can perform the Wilson's test. The Wilson's test is holding the limb, moving the knee from 90 degrees of flexion toward full extension with internal rotation and external rotation. Now with external rotation, the eminence, the tibial eminence, moves away from the lesion site and the patient will be pain-free if you repeat the same examination steps with internal rotation. The eminence will rub against the lesion and will cause pain to the patient. A special X-ray view is required to view an OCD, an osteochondritis dissecans. It's called the tunnel view, in which you do a AP view while the knee is flexed to 30 degrees to view the whole notch. On the X-ray on the right, you can see the osteochondritis dissecans lesion. And once it is separated, it can form a loose body inside the joint. MRI is the most sensitive diagnostic test for the OCD. Can appears with high intensity signal on T2 images and can show some fluid, synovial fluid behind the OCD lesion. Now, how to treat this OCD lesion? If it's a mildly painful, stable lesion, you just treat it conservatively by restricting activities. If it's loose or unstable and causing the patient a lot of symptoms, pain, then you have either to remove it if it's small, fix it in a place if it's large, or if it's large, causing a defect and loose, you can replace it by implanting osteochondral parts in its place. The stability of the patellofemoral joint depends mainly on the shape and configuration of the joint itself. As we said, that there is a dome-shaped undersurface of the patella that moves in a saddle-shaped trochlea. This movement is cephalocaudal and prevents the patella from dislocating medially or laterally from the sides of the trochlea. Another static stabilizer of the patellofemoral joint is the MPFL, the medial patellofemoral ligament. That's a ligament attached from the medial side of the patella to the medial femoral epicondyle. Patellar dislocation and instability almost always happens to the lateral side, and it is more common in females than in males and happens in the second and third decades of life. Now, at the sudden onset of patellar dislocation, the patient usually presents where he will fall, giving way, instability. The knee is stuck in flexion, and it is almost always happens while the knee at full extension. Now, the patient will see a prominence on the medial side while the patella is dislocating to the lateral side. This prominence is the medial femoral condyle, but the patient perceives it as a prominence on the medial side. The patient will present with the knee held in flexion, with a knee fusion. Palpation will cause a medial side tenderness on the medial facet of the patella. And if you perform the apprehension test, it will be positive. An apprehension test is trying to dislocate the patella from full extension, pushing the patella laterally and flexing the knee slowly. The patient will prevent you from performing the test and continuing flexing the knee. What are the predisposing factors for patellar dislocation? Now, any generalized ligamentous laxity can cause an increased excursion of the patella laterally, rupturing the medial patellofemoral ligament, like Marfan syndrome, Ehlers-Danlos syndrome. If there is a primary muscle wasting and defect, especially in the vastus medialis, that is a dynamic stabilizer, pulls the patella medially and prevents it from lateral dislocation. A wasting, atrophy, or defect in that muscle can predispose the patient for patellar dislocation. Other factors include underdevelopment of the of the trochlea, especially on the lateral femoral condyle. This is called the trochlear dysplasia. So if the trochlear shape is not this saddle shape anymore, it is flat or dome shape, this might increase the risk of patellar dislocation. Patella itself could be high up, away from the trochlea. So the movement of the patella, we said it's cephalocaudal. The first 20 degrees from full extension to 20 degrees of flexion, the patella it is outside of the trochlear groove. It's higher than the trochlear groove. And after the 20 degrees of flexion, it moves into the trochlear groove. That's why patellar dislocation usually happens in full extension. Now, if the patella is higher up, what we call the patella alta, that needs more flexion for the patella to move into the trochlear groove and put it at higher risk of having a patellar dislocation. Malalignment of the lower limb that increase the Q angle. The Q angle represents the pull on the patella, the vector pull of the patella laterally. It is formed by a line intersecting the patella and the patellar tendon to the tibial tubercle, and another line forms the pull of the quadriceps muscle from the center of the patella to the anterior superior iliac spine. Usually, this angle is around 15 degrees. An angle more than 15 degrees will increase the lateral pull of the patella and cause a patellar dislocation. Now, anything that might increase this Q angle will predispose the patient to patellar dislocation. This includes a valgus knee. A valgus knee will increase the Q angle and increase the pull on the patella laterally, causing a patellar dislocation. An external tibial torsion. External rotation of the tibia will move the tibial tubercle laterally, and this will increase the Q angle. Or an internal rotation on the femur. This can happen due to an excessive femoral anteversion. So to reduce the head of the femur into the acetabulum, an internal rotation on the femur happens, and this will increase the Q angle and predispose the patient to patellar dislocation. How to treat a patient with patellar dislocation? Usually the patella relocate spontaneously after just extending the knee. So usually the patient presented to you to the ER with relocated patella, just with knee effusion and anterior knee pain. If not, then you have to relocate the patella by extending the knee slowly and moving patella back in its place. After putting the patella back in its place, you splint the knee in extension for around 3 weeks to allow for the MPFL to heal and for the effusion to resolve. This can be done in a cast or in a knee brace. If the patellar dislocation is recurrent, then you might need to reconstruct the medial patellofemoral ligament by attaching another ligament in its place. Chondromalacia patelli is softening of the lining cartilage of the patella. This happens due to a continuous overload of the patellar undersurface. This might happen due to malcongruence of the patellofemoral joint articular surface or due to an extensor mechanism malalignment or wasting. The end result is tilting or malcongruence of the patella, leading to a contact point between the lateral facet of the patella and the lateral femoral condyle. The patient is usually a teenager girl, especially in young athletes. The pain is usually anterior and localized to the undersurface of the patella. Symptoms usually aggravated by activity, by squatting, by going downstairs. It might be associated with the quadriceps wasting as a cause of the chondromalacia and overload, or as a result of the pain, and the patient will avoid using the quadriceps. Grinding and gliding of the patella will cause pain. A grinding of the patella is a test in which you push the patella while the patient is performing a quadriceps contraction. This will cause pain to the patient. And gliding the patella superiorly and inferiorly will also cause pain to the patient. Traction epiphysitis of the patellar tendon is more common on the tibial tubercle, as the patellar tendon unload happens on the tibial tubercle while the apophysis is still not fused to the patella. The presence of a secondary growth plate in there, weak cartilage, can cause fragmentation and continuous pulling on the tibial tubercle. Usually the patient is in their adolescence. The pain is usually anterior and localized over the tibial tubercle. The tibial tubercle could be prominent and tender, and the pain is usually related to activity involving continuous pulling of the patellar tendon. This syndrome is called an Osgood-Schlatter syndrome. Can be diagnosed by doing a lateral X-ray of the knee joint, and you can see the fragmentation or the displacement of the tibial tubercle. The management is usually conservative by restricting activities that causes the pain until the apophysis is fused back to on the tibia around 16 to 17 years of age. Other syndromes with patellar tendinopathy is a traction epiphysitis of the patellar tendon on the lower border of the patella. It is less common than Osgood-Schlatter syndrome. This traction epiphysitis on the lower pole of the patella is called ascending Larsen-Johansson syndrome, and the treatment is the same, as restricting activity, preventing the continuous pull of the patellar tendon on the lower pole of the patella until the apophysis fused to the patella and the patient is free of pain.